Okay, welcome to report out for RPIW number 41. My name is Charity Bleckinger and I'm the co-lead of this team. This is just our standard work combination sheet to explain the order that we will be going in today. So this is our fabulous team. Colleen and I got to co-lead this week and we're named Team Raindrops and Sunshine. This week we really focused on the safe flow of mental health clients and necessary information from presentation at triage to admission to mental health inpatients. A number of the challenges that were occurring prior to the RPIW were safety of staff and patients, lack of role clarity and clear processes to be followed, and missing and incomplete documents and signatures when documents arrived on the inpatient unit. So this is our current state value stream map. It's kind of tiny, but our processes really looked at the client seen by the triage nurse, then the client was seen by the ED physician, the client was seen by the psychiatrist, the handoff between mental health or ED and mental health occurred, and then the client arrived on the mental health inpatient unit. Our lead time for our current state was 3 hours and 18 minutes. Our value-added time was 57 minutes. Our non-value-added time was 2 hours and 21 minutes. Our value-added percentage was 29%, and we were 71% non-value-added time to the patient. Our targets progress report, if I just pick out a couple of the key ones, we looked at part travel in terms of the armband. So the patient being admitted, client access takes the armband over to the quiet room, puts it on the patient and returns. Our baseline for that was 161 feet and our target for that was 0. A quality target we had was missing admission information upon arrival to the mental health inpatient unit where the chart was reviewed by the nurse. Our baseline was 23% and our target was 0. So this is our 5S. We did the mental health inpatient dictation room right behind the mental health nursing station. Our 5S pre-evaluation score was 1. We managed to eliminate all of those document folders to get a nice spot for all of their procedure manuals and key documents that the nursing staff as well as physicians use, tidying up the area, making it very clear where their Rosera badges or batteries go, and that all the supplies that they need are at the desk. Another picture of that. This is our filing cabinets in that space. It was kind of had everything, a great mixture of stuff on there. We managed to eliminate one of the filing cabinets and we moved their rec therapy cabinet for their adult inpatients over. And so our post-evaluation of this room was, we scored a 3. We decreased our inventory by 75% and decreased our space by 55%. And our tap time, I'll just quickly speak to, is what came out as 480 minutes, which was 8 hours, which gave us 8 hours to look at one patient, put one patient through the process. So as part of this RPIW, we really focused on the quality as opposed to the demand of putting a patient through.
Hi, my name is Ross Elton, Head of Security of Supervisor at the big hospital. I have 2 diagrams, I've got 8. The current one from the units, mental health, this is their route to pick up the patient. CCA and RN and security officer from the adult mental unit would all leave the unit to pick up the client. They would first proceed to the staff elevators on level 1 and get off on level 2. They would proceed to a admitting desk to pick up the admitting papers. Then they would proceed to the ER nurse station where they would check the paperwork. Then proceed to the quiet room to pick up the client. Once they received the client, they would exit through the back ER doors, proceed to the stairwell on level 2. They would exit the stairs on level 1 and proceed to the mental health unit. Total distance, steps, 806, feet, 1,200. Gotta get that diagram. This is our diagram. Me and Janet and Megan, we did many steps counting. So we came up with this solution. To solve this problem, we tried different routes coming and go, and we came with this solution. The CCA will phone security on level 2, stating that they're on their way to pick up the client to have a security officer meet them at ER nursing station. The CCA will leave admitting mental health, proceeding to staff elevators. On level 1, exited on level 2, they will enter ER through the back ER doors and proceed to ER nursing station where security will be waiting. CCA plus security officer will receive the paperwork and together proceed to the quiet room to pick up client. They will exit through the back ER doors, proceeding to the stairwell and level 2. They will exit the stairwell on level 1 and proceed to adult mental health unit escorting client. Total distance is 688 steps, 1,032 feet. Now, we saved 118 steps, 226 feet. No longer will we need. We'll just use the CCA and the RN, and the security officer will stay in the villas at all time. We'll use the security officer upstairs, and they will meet at the nursing station. They will no longer have to go to admitting. So we saved a few steps there, and like I said, we don't have to use the security officer. The security officer never has to leave the villa or the RN. Thank you.
Hi, I'm Megan Cassavant. I'm one of the registered nurses in the ER department. One of the problems that we identified is that a lot of the ED staff in the department wasn't using the mental health flow sheet, which I can understand. When we actually took a look at it, it was very quite old and ancient. So our goal and what we kind of focused on was revamping a new flow sheet that would actually get the RN going into the room, assessing the patient, and which is a good thing because when they went to go talk to the patients, one of their biggest concerns was when they were in the ED department, they were finding that once they were put in the quiet room or whatever room, they were feeling neglected, they were feeling that we weren't paying attention to them, and they weren't having that nurse-to-patient contact like they wanted. So what we did is we took that form, we talked to a lot of staff members, we did try and revamp it. So two things will come out of this. The first one is that will make it a lot easier for the ED nurse to go in and assess the patient. I will be the first one to admit that when it comes to assessing a mental health patient, it is very daunting and it is very intimidating. It takes a very special nurse to do that. So with this new form, if you can go to the second one, it does kind of guide you through it quite easily. It's a check form. It does cue the nurse to ask specific questions that are really geared towards that mental health patient, so it makes sure that we're not leaving anything out. The second thing is, with this form, it is getting the ED nurse into the room, talking to the patient, introducing themselves to this patient, so they actually realize that, okay, this is my nurse. If I have any questions, this is who I'm going to go to, and at the end result, the patient will feel a lot more comfortable in the department, and they'll feel that they have better nursing care than they did before.
Hi, my name is Janet. I work with the nursing supervisor's office. One of the problems that was also identified was that there was no clear information passing between emergency room nurses and mental health nurses. So we came up with an SBAR that is the tool that we use for all our other clients being admitted to the hospital. So So the changes that we put on the mental health SBAR is whether they're certified or not, and who they're accompanied by to go down to mental health. The other change was if the restraint chair is needed or not. Emerge doesn't have a restraint chair, but mental health does, so if they need to bring it, they can bring it up prior to getting there and realizing they need it. And then just by having this SBAR, it's faxed down prior to the patient going down. After the SBAR goes down there, there's a nurse-to-nurse referral done. So there's that actual communication between the RN and the RN, so that improves communication. The other problem that was identified to us is that people didn't understand which information needed to get down to mental health. So we came up with a checklist, and the checklist just goes through everything that is required by mental health, so the emergency room nurse can get it all prepared prior to the patient going down. We came up with a number of things that need to go down, and on the bottom, both emergency room and mental health staff will sign it, ensuring that the information is at least, they understand if it's not there and why it's not there, if the communication is there, again, opening up the communication between the two. We also came up with a work standard for how the patients are now being admitted to mental health. All our other admissions throughout the tower go through the nursing supervisor, and again, as opening up communication between mental health and the hospital, we are now going to have our mental health patients go through the supervisor also. We will be aware and help get the room numbers for the mental health staff, letting emergency room know when mental health will be available to take their patient. And the way that we opened up so that everybody knows where to get these new forms that we've started, we put them just outside the quiet room where most of our mental health patients do go for assessment. So we have a folder there that has our flow sheets, the SBAR, the checklist, and also, as you'll hear later on about our pamphlets are in there too.
My name is Dr. Odoko, and this RPIW generally focused on the safe flow of mental health patients coming into the hospital. So generally, mental health clients come in either through their GPs here, some of them coming straight up, some coming from hospitals outside PA, and some come from the jail, and some come from the police centers as well. The one thing we've realized is that mental health clients are not screened effectively. So this RPI looks at screening them effectively, so medical problems will be identified quicker, and also those clients can be deemed medically stable for them to manage on the mental health ward. And one of the, most of the cases we see are usually alcohol problems, substance abuse, overdose, smoking, change in behavior. Like you have them being very aggressive. With this RPI, it's kind of like focuses on mental health patients being safely evaluated by ER doctors. Also, as our mental health clients tend to have a lot of concurrent problems, such as HIV, substance abuse, and with this RPI, we looked at the chances of those being taken care of adequately, so that by the time we get those clients, that they have been kind of like screened effectively. So what we are trying to achieve is a uniform standard for patients that are sent to us from all over the area. That there is a uniform protocol in which patients are seen and treated at the time they come to our hospital. I go to the address sheet. So these are patients coming into the hospital, so they come in through various routes, and by the time they come here, there's a lot of confusion on what has to be done basically. So we're looking at a way in which they can be screened effectively, so that their medical problems are kind of like tackled effectively, and take over the care. So hopefully with this RPI, we've put in a lot of measures that hopefully by the time the clients do come in, eventually by the time these psychiatrists are seeing them, they'll be medically stable, and things will kind of like flow more effectively for our patient generally. That's what the RPI does. So Dr. Gallis will talk about medical stability.
Thank you. Wow. So Dr. Odagu and I spent basically this entire week engaged in a very enthusiastic, as you can imagine, conversation surrounding the idea of medical clearance. Thankfully we have Leanne, who was sitting beside me, to sort of act as an intermediary between the two of us when we weren't speaking. Sounds not sure. So we have scoured the internet and textbooks to try to help guide us. But we were really sort of unable to plagiarize shamelessly, unfortunately, to determine what standard there is for medical stability and medical clearance. But using an emergency textbook, I've tentatively convinced Dr. Dagu to use the term medical stability instead of medical clearance. Medical stability means that within reasonable medical certainty, there is no medical emergency. So using that term, we did finalize some work standards, some of which we already do currently in Emerge, and some which we needed to improve upon. And so these are them, and hopefully we'll disseminate this to the surrounding areas as well, so like Nicklin, Alfred, Tisdale, places like that, so they know what to expect for a psychiatrist is expecting for medical stability to be sort of deemed for a patient. Number one, best practices for the physician, your physician, to perform an appropriate history and physical on all mental health patients. Number two, acute medical issues shall be addressed by labs, treatment, and appropriate observation when applicable. Three, to help ensure that the mental health patient remains medically stable, their past medical history should be reviewed in order to ensure that they have appropriate treatments ordered or initiated. And number four, new medical conditions that need to be addressed include, but not limited to, like diabetes and hypertension, will require a reasonable plan for treatment with medications and further investigations. And lastly, to ensure that patients are safe to receive appropriate mental health related medications and treatments, a standard mental health lab workup shall be performed on all mental health patients. So, we have created a mental health lab workup where we've kitted all the necessary lab requisitions together in one spot. And then we also created a beautiful flow sheet. Yeah, so that's the kitted lab requisitions. And then we created a flow sheet to ensure that labs are done appropriately and not overdone on the patients that recur and frequently visit Emerge. They don't need labs every week. If they're stable and it's the same issue, they can get labs done every 3 months. So once the patient has been deemed medically stable, the psychiatrist then see the patient in a timely fashion. Now Deanne will talk about the improvements we made on admission paperwork. Thank you.
Hi, my name is Leanne Petrosky and I'm from Cardinal Top Regents. I was lucky enough to be a participant in this region for this great RPIW and with this great team. So we put together an admission bundle with standard documents that would support the safe, seamless care of the mental health patient. We wrote up standard work for the admission bundle for mental health patients based on what we felt was consistent and necessary documentation that needed to follow the mental health patient for the safe flow of information. In this bundle, which is kept in the ER, it is all together, so no one's looking for different forms. It's packed together. So some of the things that are in this bundle are, the first thing would be the consult sheet. The next thing would be the mental health intake form, physician clinical progress order forms, and then the fourth item, which is something that we created this week, which was the psychiatry admission bundle, or psychiatry admission order. Right? So this is a new form. I'm going to come back to this, but I'm going to complete the bundle. So then we have the doctor's orders and section 24 form, and then lastly, if required, the voluntary admission form. So we created this new psychiatric admission order so that it would follow the mental health patient from the emergency department to admissions on the mental health inpatient unit. So some benefits of the form were that it's all tick boxes, so it's easy to check off. It's screening on one form and it's easy to use. So it's going to speed things up, we hope. Exact same form for each mental health patient coming through the emergency department. So consistency and not a lot of guesswork. Legibility was an issue, so it's going to be easier to read. It won't have to be transcribing people's handwriting, that kind of thing. And basically the main thing is it allows for best practice standards for the mental health patients, so the end result is better for the patients, staff, and physicians.
Hello, my name is Tina, the still happy volunteer at the Victoria Hospital. I have the privilege to be part of our wonderful team called Raindrops and Sunshine. Mental health wellness was our main focus. Raindrops depict darkness, and sunshine the promise of a brighter tomorrow. My participation was that of a patient. In my mindset, I adopted that role, suffering from severe depression. Feeling downtrodden and lost, I came to the hospital willingly. Once inside ER, I was led to the quiet room. 4 bare walls, a door that closed, and no window whatsoever. You sit and you wait. I feel claustrophobic. I long for an outside line that directs me to a window. None there. Staff, nurses, doctors, plus our team felt it beneficial to add a window to the quiet room door. Patients can be observed without opening the door and will not feel so isolated. Our efficient maintenance crew promised this job will be done by next Tuesday. Information pamphlets are a wonderful tool to become familiar with surroundings. My co-workers, Jennifer and Leanne, worked tirelessly at producing a great brochure titled While You Are With Us. It contains easy-to-read suggestions on what to bring, what not to bring, who your care team is, making phone calls, etc. Staff in the mental health unit gave positive feedback, and they have them available now. Patient first, giving them the best possible care. That is our goal. Reducing the raindrops and adding more sunshine is something we all can do by reaching out, understanding, and rejoicing in the progress made. Thank you.
Geez, that's going to be a really tough act to follow. My name is Jennifer Conley. I'm the CEO from Athabasca Health Authority. I'd like to take this a quick opportunity to thank the KPO. I've done most of my Lean Leader certification training, and I have one more RPIW, so thank you very much. One of the problems that we've identified through this process was the lack of communication for family members or friends who may be bringing a mental health client into the emergency department. A few years ago, I had the experience where I brought my dad into the emergency department. He was hallucinating and suicidal. He wasn't dealing with the loss of my mother very well. We sat in the quiet room for many hours waiting to be seen. I was scared and unsure about how I could help my dad. And there was very little communication from the staff because it was a very busy time. He received some medication and he ended up leaving without having his issues resolved, and it was very frustrating. Even though I'm a health professional, I didn't know at that time how I could help. So the measures taken were that we developed a pamphlet for family members who are accompanying mental health patients to the emergency department entitled How to Support a Loved One in Crisis. The pamphlet speaks about how a family member can assist a person in crisis, such as recognizing changes in behavior, developing a plan for when crisis happens, and how to advocate for the client when they can't for themselves. We also included contact information for the Prince Albert Parkland Health Region Mental Health and Addictions Outpatient Services, the helpline number, and mobile crisis. As for the results, we spoke to a number of staff in the ED and the mental health inpatient unit, and they were very receptive and appreciative of having this information provided for patients and families. But as well, we shared it with some of the patients in the unit, and they really appreciated some of the information entailed, and also the contact information for where to go for help when you're in crisis. Thank you.
Thank you. My name is Colleen Toy, and I'm the happy and still standing colleague. I'm not happy because it's Friday, well, that's part of it, but I'm really happy, as you can see, the exemplary work that this team has actually accomplished this week. What we have is, if you could move on to the newspaper. We did have our newspaper, and I am over time, so I'm going to be really, really quick. Our newspaper really reflects all the processes that were put in place this week. You won't see 100% on all of them because unfortunately we didn't get a big chance to do some timings and to actually get numbers down. But many processes have been put into place, and it's really skills checklists and some logistics around the process that we have to get accomplished. If we go to the value stream map. So the value stream map, as Charity said, wait times, and the lead time will actually down the road be reduced. So our value added time went from 29% to 40%. And if you could go to the percent load chart, I'll be able to show that to you. This is the first percent load. Just pull it up a little bit more. Yeah, first percent load really showed most of the touch time was really the psychiatrist or the ED doc if they were doing the admission. And if you go to the post percent load chart, you'll really see a jump in that touch time by the ED nurse and even the ED physician. And that's just from the great work that the team did this week. The target sheet is the final little bit of required information I have to share, but I'm just going to talk about, because you'll see there's a lot of areas that hadn't been measured. Walking distance, because we eliminated that registered nurse coming from mental health inpatients 2 or 3 times a day. We got rid of that walking distance completely, and on page 2, we increased that RN capacity by 100% by leaving her on the unit. So then, workshop summary we'll just put up briefly. And I was asked to read the first line. ER staff and mental health staff, after 5 days of butting heads, can come to a compromise. And, you know, all kidding aside, there were some really difficult conversations that were held this week, and the team really managed to slog through it and come up with some really, really great processes. So we're really hoping for continued improvement. And so we thank all those that helped us. One more page, please. Your job's not doing that well. This is our thank you, and there was many people we had many interviews with psychiatrists, docs, staff, clients, and without them we couldn't have accomplished this RPIW. And on behalf of Charity and myself, we can't thank this team enough for all the really, really wonderful work they did.